On behalf of RSNA, thank you for joining us today. My name is Dr. Jeffrey Klein, and I will be one of the moderators for today's webinar. I am a thoracic radiologist and professor of radiology at the University of Vermont College of Medicine and the editor of the RSNA's education journal, Radiographics. I also serve as the RSNA board liaison for publications and communications. As you work to address COVID-19 in your practice, I wanted to let you know that this webinar is one of the many ways the RSNA is trying to reach out to the radiology community by providing education and resources on COVID-19. You can find these resources on the COVID-19 section of the RSNA's website, which is updated weekly and sometimes daily. A link to this page will be provided in the resource panel for today's webinar. Now I would like to introduce Dr. Bien-Sue Tan, who will be co-moderating today's session with me. Dr. Tan is chair of the Division of Radiological Sciences at Singapore General Hospital. He is also a member of the RSNA COVID-19 Task Force. Dr. Tan, I will now hand it over to you.
Thank you, Dr. Klein. I'm very pleased to be co-moderating part 2, covering very important topics of second surge preparedness and getting back on track safely. With us today, we have Doctors Lionel Cheng, Martha Helbran, and Dushan Sahani. Before we formally introduce the speakers, there are a few things to let you know. You may follow the steps on the screen and in the chat panel to claim 1 CME credit for the webinar. Here is the disclosure and accreditation statement. And the RSNA disclaimer. Please use the question panel to submit your questions during the webinar. This webinar is being recorded and will be posted on RSNA's YouTube page within about 1 business day after the event. Now I'd like to introduce our first speaker, my colleague, Dr. Lionel Cheng. Dr. Cheng is a senior consultant diagnostic radiologist at Singapore General Hospital and also the director of clinical operations in the Division of Radiological Sciences. He's currently overseeing external COVID-19 operations for his hospital and health service system. Dr. Cheng, please.
Good morning, and thank you, Dr. Tan, for the introduction. This morning, let's think about how to prepare for the second surge and beyond. In part 1 of this webinar, Dr. Judy Yee mentioned the 3 waves of the 1918 flu pandemic. As you can see, the second wave was much worse than the first. Many of us are probably around where that red asterisk is, just emerging from the first wave. So the first surge was a time of survival, rolling with the punches. My talk today focuses on what we're going to do in the time here indicated in blue after the first wave, before the second surge comes. How we can make best use of this time so that we can thrive in the new normal. For my hospital, we experienced our first surge 17 years ago, actually, with SARS. SARS left really deep scars in our department, as covered by my colleague Dr. Tae Kyung Hyung in part 1. It has shaped our planning and our development in the subsequent years. And the COVID-19 wave we just endured was similar in many aspects, but also different in important ways. So in preparing for the second surge and beyond, we continue to develop on what we have been doing since SARS. And I will cover 3 broad strategies for the second surge and beyond, illustrating each with a few examples from our own experience. These 3 strategies are build, sustain, and adapt. Well, we don't presume that our experiences will be applicable to all other locations, but we hope that our successes and our failures will be helpful lessons for others. But before I proceed, just a brief introduction of our hospital to provide context of the changes we implemented. So the Singapore General Hospital is the largest hospital in Singapore with about 1,800 beds. Our Division of Radiological Sciences is also the largest in the country with 3 separate departments and a staff strength of more than 700. As of middle of June, the hospitals in our health system have cared for over 5,000 COVID-19 cases. So let's start with strategy 1, which is build. So the central idea here is to create capacity before you need it. To use a running analogy, it is preparing for the next race. So applying this concept to different domains, one can think about increasing the footprint, getting more equipment, new sources of manpower, increasing operating hours, and creating new workflows. Let me share some examples of what we did in our hospital. One good example is our partnership with our emergency department. Our original ED had a straightforward layout with a screening or triage area, as you see here, a fever area, and a critical care area. But as the first surge progressed, the ED expanded into an adjacent day surgery center. So this expanded area catered for febrile patients or those with respiratory symptoms. And our portable radiography capability also expanded in tandem. But the ED expansion didn't stop there. Because of the surge demand, they expanded to a pedestrian link bridge next door, so it was just housed underneath this skyway, and our portable X-ray capability grew and supported this area as well. The ED even expanded into a multi-story parking garage. So this purpose-built parking lot was specially designed after our first experience with SARS. In part 1, my colleague Dr. Tay Kiang Hyong talked about how this parking lot was configured to serve as a fever screening area and had pre-built lead-lined rooms which could be used for radiography. So radiology also followed and expanded here. More recently, our hospital started building a container ward in another open-air parking lot. So here we had 50 negative pressure container rooms, which are part of extra capacity that the hospital is building. Do we need the extra space at the moment? The answer is no, but this additional capacity was built to prepare for the next surge. So to support all these expanded services, we also had to expand our radiology footprint. We bought and borrowed additional portable radiography units. And at the multi-story parking garage, we even brought in a container to house additional X-ray units when the workload became too high for one portable X-ray team to handle. Beyond radiography, CT was also a very valuable and stretched resource during our peak COVID-19 times. So we had serendipitous alignment of a vacant old cardiovascular lab space next to our department and a willing vendor who was able to lend us a CT machine. So we installed this CT in record time, slightly over a month, from concept to operations. Now this extra CT has proven invaluable in load balancing our inpatient CT requirements for high-risk cases while maintaining baseline CT operations. The next strategy is sustain. So here we ask ourselves the difficult question: can we keep this pace for the next 2 years? So the running analogy commonly used during this pandemic is that what we're doing is a marathon and not a sprint. So the possibilities we can entertain here in the different domains include alternating work sites, adjusting work timings for the long haul. We think about preserving supplies, being more efficient, and simplifying processes that were probably cobbled together quite hastily and inadvertently complicated. So the story of our container-based X-ray continues. We saw that our anesthesia colleagues had devised a clever telephone booth-style swabbing station, modeled after what was done in South Korea. So we asked ourselves, could we have a telephone booth X-ray? So a very capable team of radiologists, radiographers, and anesthesiologists conceptualized and operationalized this new container booth X-ray facility. So as you can see in the pictures here, the patient comes into the booth for his X-ray and he remains separated from the radiographer during the X-ray. So the PPE consumption rate for our radiographers dropped. Well, many of our protocols also developed in haste at the start of the pandemic were very complicated. So we made a deliberate effort to refresh and simplify them. So for example, the inpatient PPE permutations were protean. So in time, the hospital aligned 3 types of wards: high risk, intermediate risk, and general, so that all protocols, imaging protocols, including PPE, could be streamlined by the ward type. So that just made things easier for people to comply. Now, safe distancing and infection control requirements also reduced the throughput of our imaging centers. So we no longer were able to have crowded waiting rooms or double booking. We needed a more dynamic, sustainable appointment system. So what we did was we fast-tracked a precision appointment concept, which we originally developed for a new hospital. So this entails a just-in-time appointment. So we envision scanning a patient having an appointment schedule that dynamically adjusts itself. So depending on the patient load that day, whether there are no-shows, patients turning up late, so that each individual patient can get an updated appointment time right down to the minute if needed. So patients arrive, go straight to where they need to be, get scanned and leave. And all pre and post-scan issues are sorted out via teleconsults. So we reduce or minimize the dwell time of the patient in our department, literally parachuting them in for the scan and then leaving. So we recently published more about this in the Journal of the American College of Radiology, in the reference at the bottom of this slide. The third strategy is adapt. So this centers around the idea of being nimble. And we remind ourselves that not only is this not a marathon, but it's a special marathon with intermittent sprints. So there will be times where we have to fire up reserves, reconfigure, improvise, and embrace new roles. So back to our expanded ED. The work at the pedestrian link bridge and the multi-story parking garage have tailed down significantly, and many of our seconded personnel have returned to our department. But our staff remain ready to be activated at short notice and to scale up and support again when the situation calls for it. So the protocols and equipment are in place, and our people are psychologically prepared to respond. Even our infection prevention and control measures must adapt. When we did our very first COVID positive CT, there were many bells and whistles. I remember we had rehearsals to practice the flow, extensive room prep, post-scan terminal cleaning. For the first scan, our CT was effectively down more than 5 hours in total. Now, as we cohort the high-risk cases and optimize our processes, the downtime has dropped to 2 hours and below, and we aim to bring it down even further. Being nimble also means having our people doing work outside their comfort zone. So here you see a collage of residents, radiographers, radiologists, nuclear medicine physicians, nurses, all who have been deployed to the ED, COVID-19 care facilities, and even external outbreak sites to help in the national response. And all this have significantly raised the profile of radiology. And we need to capitalize on these new inroads and relationships to shape future hospital operations. And finally, we need to be adaptable when responding to breaches in defense. In spite of our best efforts, it is likely and practically certain that staff will come down with COVID-19, and we must prepare for it and mitigate the damage in the event of such a case. So everything we do must change, even something as fundamental as how we take our breaks and eat. So here you see safe distancing being applied to lunch break tables in a conference area in our hospital, and also how plastic barriers were erected to allow safe interaction of staff during meal times when masks are down. So in conclusion, as we strategize how to thrive in the second surge and beyond, we propose that the concepts of building, sustaining, and adapting are useful frameworks to orchestrate our responses. We need to prepare for the next race, sustain it like a marathon, and adapt to the intermittent sprints. Thank you for your attention.
Thank you, Dr. Cheng. Dr. Mara Heilbrunn will speak next. Dr. Heilbrunn is a member of the Emory University Department of Radiology and Imaging Sciences Executive Committee. She uses her background in outcomes research, informatics, education, and quality improvement to study and impact medical decision-making, evidence-based guidelines, and clinical operations. She believes that the most appropriate, personalized, and patient-centered care is provided when the power of standard work and metrics are harnessed to assess and improve patient care. Welcome, Dr. Heilbrunn.
Thank you, Dr. Klein, for that very kind introduction. It's my pleasure to build on what Dr. Cheng just presented. I will focus on the granular details of what we need to understand operationally in order to adapt our workplaces and workforce to our new normal. That is, living and working with a highly infectious disease like COVID-19 in our communities. I will focus on three main points. First, the importance of understanding the modes of COVID-19 transmission so that we're implementing the measures that keep our staff, faculty safe and healthy. How we go about leveraging guidance from internal and external infection prevention leaders and using that guidance to implement the measures necessary to operationalize a culture of safety, including flexing hours and locations for delivering patient care. Finally, I will tie this into a laser focus on our patient care mission. While the priorities and balances necessary may be slightly different in academic and non-academic centers, providing our patients access to the best, most necessary, and appropriate care by ensuring that our faculty and staff remain united and available despite our creations of safe spaces. Importantly, I do want you to know that I'm going to spend my time talking about care delivery in diagnostic and interpretive spaces and not procedural areas due to the complexity in those spaces. So let's start with the first point. In order to create a safe space, we really have to understand how this disease is spread. This is, of course, a challenge because COVID-19 is a new disease and we're constantly learning more while we're in the midst of adapting. Thus, our long-term strategy is going to build on an expectation of flexibility and change. So what do we know? This is our current best understanding of how one becomes infected with COVID-19. An infected person transmits live virus to an uninfected person by being in close proximity. The thought is that close proximity is something around 6 feet or 1 to 2 meters apart. And how does this happen? When in this close proximity, respiratory droplets containing the virus are spread from the infected person coughs or sneezes into the room. The droplets then land in the mouth, noses, and some suggest eyes of nearby people. The risk seems to be significantly greater indoors than outdoors. And the reality, of course, is that our workplaces for care delivery, reading rooms, modality rooms, control areas, IR suites, they're all inside. So this is what we are going to have to deal with and adapt to. We can't move our work outside, at least not to the best of my knowledge. So it is understood that people are most contagious when symptomatic. However, there's an asymptomatic and pre-symptomatic cohort who have also been implicated in COVID-19 transmission. Working around the risk from this population is where we must adapt most concretely and then adjust our adaptations as we refine understanding around prevalence, transmission risk, and effectiveness of mitigation strategies. It may be possible to get C-19 from touching a surface on which live virus has landed and then transmitting this to your own mouth, nose, or possibly eyes. Much like asymptomatic spread, this is not thought to be the main source of risk. The next part of this talk will show specific measures that we at Emory and other places have taken in order to implement the safety strategies at work. So the first thing is to create flexible staffing by location. This manuscript from my colleague Srini Trendanapani at University of Alabama at Birmingham describes their strategy for rapid deployment of home workstations. At Emory, we did a similar strategy. We enlisted healthcare support for purchasing more than 30 home workstations and repurposed another dozen devices that were being replaced to facilitate an upcoming PACS upgrade. With these measures, we were able to provide more than half of all of our faculty with home workstations. In this way, we were able to provide care for patients across our hospitals in more than 5 centers and imaging centers while limiting the number of people that were actually coming on site to work. Additionally, we developed strategies for flexing the hours of staffing for our physicians. The graph shown here is a version of what we implemented in my abdominal imaging division on our MR service. We have 2 faculty who start and end at different times of the day, as well as 2 trainees who also start and end at different times of the day. It's important to note that maintaining this staffing strategy long-term requires a significant mindset change, especially in a very traditional academic setting. Many care delivery models are being flexed with an emphasis on increasing the hours and days of patient access to image acquisition. However, the mindset around access to physician remains limited to business hours. By maintaining this flexibility, I see this as an opportunity for radiologists to change that narrative about our availability to our patients and to set the stage for our future workforce, the current trainees, who, by training an environment that takes patient-centered approach to doctoring, will show us the long-term improvements in care and associated professional satisfaction. However, this example here also shows an overlap in the single reading room for over 4 hours. Thus, we have taken the step of working with our architects to examine the layout of our reading rooms. So again, this is one of our shared workrooms. And as you can see by the circles, which indicate a 6-foot radius, each one of our people are highly prone to run into each other and cannot maintain a safe distance from each other. So what do we need to do? We worked with our architects and came up with designs that actually moves the desks into different locations or move them while off-site. Additionally, we leverage our home workstations to provide continued work when we can only have smaller people or a smaller number of people in the room. So once we've done this, moved our people out, separated them in the workspaces, what's the next step that we need to do? We really need to make sure that our workforce is healthy. And this is important to both each other, but also to our patients. They want to know that we are taking precautions necessary to keep each other safe. For example, you can perform temperature and symptom screening at the workforce. We do this at entrances to facilities and our work sites. Others have championed using online tools where people attest beforehand that they are healthy and they are not having fevers. The other thing that's really critically important is that we enforce the policy in our shared spaces that masks are required and expected. And this is going to be both in our public spaces, in our hallways, coming in and out of the hospitals, in the elevators, and then in any of our workspaces where it is not possible to maintain 6 feet of distance. This, for example, is signs that we submitted, that we have entering every one of our control areas in all of our workrooms. But then once we have done this, we've created this space, we've moved people outside of the hospital setting, we have reduced the number of people that are in any given room, we have an issue that comes up, and that's about maintaining our connections. So what is the risk from our emphasis on distance and space? Well, I wanted to take a moment to look at the mission statement for my department. The Emory Department of Radiology and Imaging Sciences is a community dedicated to the promotion of health, discovery and innovation, and educating the future healthcare workforce. We embrace and celebrate a collaborative culture, adaptive approaches to continuous innovation, and aligned partnerships in patient-centered care. Community, education, collaborative, patient-centered care. If we separate ourselves, we're really at risk of losing sight of these important things that actually are the reason why we're here and why we move forward. So what have we done? The next step in the strategy is really to take advantage of your digital communication tools, just like we're doing right now by lecturing locally and sharing around the country and around the world. We increase our network. We partake in virtual conferences. We actually had challenges because at Emory, we do have our trainees all over the Metro Atlanta area. By really emphasizing and improving our virtual conferences, we were able to have more resident attendance, and so actually created community through teaching. Additionally, during the time of, we really ramped down the number of people that were in-house. We had our residents participate in online remote readouts and hot seat conferences, and we actually had more residents listening into a readout and going over the emergency cases than we would normally. And this actually really allowed us to create some consistency in the learning for our trainees that doesn't have in a one-on-one format. And the next thing that we did is, again, we leveraged our multidisciplinary patient care conferences and encouraged the participation of physicians from all around the area and have improved satisfaction. And the other thing that we did here is that we leveraged electronic tools of Microsoft Teams to be able to create daily check-ins so that we have much more visibility into what we're doing. So really, in fact, the disruption of COVID and the need to move people off-site has allowed us to increase our day-to-day connections with each other. And in doing that, we also have taken time, and you have to take time to emphasize the social networks. Most of our sites who are trainees have had some kind of virtual graduation. And while this is very different than what it was, it also created a really fun and interesting things. Many of the divisions in our department have had social Zoom cocktail parties. There are other things that we can do in this team building that is really critical and what we need to keep in mind as we move forward. And again, when we have this understanding of how the disease is transmitted, we can create safe spaces for in-person education, including social distancing, masking, and hand hygiene. So finally, for a long-term strategy, it's critically important that we understand the risks. Then we flex our hours and locations for performing work. We emphasize a culture of safety to promote measures and shared spaces, and we build social connections even when it turns out that we are separated. With that, I'd like to pass it on to my colleague, Dr. Shahani, who will talk about more of the future directions. Thank you very much for your time.
Thank you, Dr. Halbrand. Dr. Dushan Sahani will speak next. Dr. Sahani is a professor and chairman of radiology at the University of Washington in Seattle. He's an international expert and leader in hepatobiliary and pancreatic imaging. He's currently involved in investigating new CT technologies such as multi-energy scanners and their impact on patient care, patient safety, healthcare costs, and CT workflow. Dr. Sahani has contributed over 330 peer-reviewed original articles and reviews to medical literature, numerous book chapters, and has co-edited 2 textbooks. Welcome, Dr. Sahani.
Thank you, Dr. Tan, Dr. Klein, and RSNA for this unique opportunity to contribute and share our perspective on this complex topic. I'm thankful for my co-panelists who have laid down a great foundation for my talk. I'm in Seattle, and I hope that what I share with you is not unique to our own practice. Now, we all know imaging departments contribute a lot. They support many clinical services in the diagnostic realm as well as for interventional care. And many important decisions are based on the services we provide. Now, as we move towards recovery, we have to keep in mind our existing backlog for the deferred elective procedures. We need to be also thoughtful of anticipated demand, daily or weekly demand, and also the new demand and growth opportunity one had planned for the health systems. Now, if you don't factor these things, so you risk negatively impacting care delivery, length of stay, and health outcomes. There are also challenges of leakages of patient out of your health system, and it's not just imaging, you lose other services as well. And finally, it also impacts the bottom line, which helps support many other services within the department. Now, when you plan the recovery, we have an overarching goal to ensure that we have a capacity to accommodate the surge in imaging as we move to more normal operation. And it's also critical that since COVID has disrupted our operation, we redesign the key processes involved in the radiology operation, whether it impacts scheduling or provision of services across the health system. Now, to meet this goal, we will need to develop image prioritization criteria based on the backlog as well as the existing demand. We will have to quantify the backlog to identify resources and right investments. We need to provide staff and providers across the continuum with discrete goals for scheduling based on targets and backlog volume. It is critical we optimize the efficiency of imaging process because that will support many services. We have to be thoughtful about expanding capacity as we have increase in volume, given the challenges currently exist with this pandemic, as Dr. Heilbrunn had outlined earlier. So we need to think about expanded hours during the weekdays, as well as having a regular schedule on the weekends to match the demand. Now, this success is predicated on having certain things in place. We need to have a COVID testing for all procedure patients, both to protect our staff, but also other patients. We need to also have a plan to expand these testing to all type of patients coming in our system. We need to have measures for PPE and other safety devices. We need to deploy efficient operational metrics and dashboard and analytic tools to help our physician and operation leads. We need to have full access to imaging modality facilities at each location. We need to validate our current workflow. We need to continuously monitor our success through KPI statuses. We need to communicate effectively to build the team, and also in the radiology side, but also across the health enterprise with our collaborating partners, and also have some regular team meetings in this space. Now, what we currently understand of this complex pandemic based on the science and common sense is that we have passed the initial hump where we have applied the hammer. That means the stringent measures of lockdown, social distancing, aggressive testing. But the real fight with COVID pandemic has just begun. Because till we don't have a vaccine, or there is sufficient transmission in the population through herd immunity, we will have to dance, we will have to monitor the patient data and be agile as we improve our operations and workflow. Now, it's also critical to remember that the current infection rate or prevalence in the population is anywhere from 2 to 3%. And to build a herd immunity, we will need more than 60% infection rate. Now, having said that, as we plan our recovery, we need to follow some principles. One is we need to be thoughtful with our operation so that our recovery is gradual. We don't suddenly open up all our sites of operation. We need to be creative with our operation. We will have to regain the trust of our patients because there is a lot of fear, especially on patients who have elective type of procedures. They will be worried about their care, so we have to put measures in place to build that trust. And most importantly, we need to protect our most valuable asset, which is our employee, our frontline staff, and others. Now, University of Washington is a great enterprise, but also a complex health system. As shown here, we have a medical center, big medical center, and we have other sites of services for specialized care. Now, it's critical that we create a steering committee or a task force which creates alignment across the sites. This also is a great tool for communication. It empowers your team, and they can deploy unique solutions which are relevant for each site. And also, there are chances of innovation that comes out through this process. Now, patient communication is key, and this has to be seamless. And one way is how we are communicating with our patient is through proactive scheduling and texting the schedules to our patient, and ensuring that they have instructions for PPE use, but also they can cancel or reschedule their appointment by simply texting back. We have also explored self-scheduling options, and this idea came from the growth in telehealth programs we have seen, where patients prefer having being empowered with these decisions. So if we started with ultrasound, now we are expanding to mammograms, and slowly we will expand to other services. And this is very popular with our patients. Now, for to regain patients' trust, it is critical that there are ample signages to communicate precaution to what is being taken. Everyone is masked. There is mandatory masking. There is ample hand sanitizer. This has been discussed earlier. We have open hallways, online registration, so patients don't have to have minimal time in our facility. We text our communication to our patient for their readiness, so they don't have to come and spend additional time in our waiting rooms. We have taken measures to ensure continued physical distancing for patients and workforce. To enable that, we have restricted entry to a patient and maybe one family member. We have staggered appointments to reduce crowding in the waiting room. We have expanded testing to all patients undergoing IR procedure or any aerosol generating procedure. And also we have expanded this for frontline provider, the testing. And our hope is to expand this to diagnostic exams over time. Now, mandatory masking is critical because it's very visible. Patients gain tremendous confidence when they see us being serious about our own and others' safety. Now, hand hygiene, patients might not be able to see it, but masking, they will see it very well. So it's critical that we have a mandatory masking, and we encourage patients also to come in. Now, as we move to the operations, even though radiology is nuanced and we have many types of modalities and services that we provide, it's critical to focus in few areas. So for us, we created teams based on modalities, and these teams constituted physician leads, operation leads, technologists, schedulers, IT personnel, focusing on the top 4 modalities and one service, which is IR. And as we heard from a previous speaker, IR is a more nuanced and complex service, and it requires an attention like surgery. Now, we need to also be thoughtful that since we are moving into a new era, we should look for opportunities to improve our workflow. And the work groups that we created is looking at the entire process map to identify modality operational efficiencies. For example, smarter scheduling is a great option for MRI, where we have to spend a lot of time changing coils, and in the time of this demand and surge, this is helpful. Shorter protocols, especially for MR, is critical. It minimizes patient time on the scanner and in our facility, but also gives us more capacity. Site-specific exams, so that patients who have simple type of exams, screening exams, performing them closer to the place of stay is critical. Streamlining our processes, and then also it's critical to address no-shows and same-day cancellation, because you can recover in terms of adding capacity once you have these problems. Now, it's also critical that we continuously monitor our success through some key performance indicators. And what I'm showing you here is the data for CT scan. This is a enterprise-wide volume for first week and second week of June. The black line is our baseline pre-COVID, and the green is our target based on our existing demand and the backlog. And you can see this gives the entire team a great perspective of how we can accomplish our big goals. And finally, we need to be thoughtful about long-term opportunities here. Since COVID has disrupted our services, it's critical that we plan for a longer haul, looking for even IT tools for dashboarding, for KPIs, for better schedulings, for smart scheduling, self-scheduling, collaborating with other departments to build some contractual obligation and partnerships, explore standardizing advantages offering at each site to load level, investigate other opportunities for expanding hours of services. And also, as we are thinking of long-term, we need to also plan for investment in modalities like, mobile technology for MRI and CT scan. We already have for mammogram. We are expanding now to ultrasound, and we will also plan for CT and MRI scan. It is not just relevant to pandemic, but also for improving patient access. So in summary, I hope I have interacted with you, and I have educated you that as you plan for recovery, be thoughtful with your operation, be gradual, be deliberate, regain patient trust through various measures which are visible through better communication, and also create a great team and protect your frontline staff and employee. With that, I thank you all for your kind attention.
Thank you, Dr. Sahani. We now come to the Q&A segment of this webinar. Now, while we await for more questions to come in from the audience, I'll start by asking each speaker a question each. Let me address Dr. Cheng first. What is the one thing that has been done that has allowed our healthcare system in Singapore to successfully accommodate the large second surge of COVID that we have seen? Dr. Cheng?
Thank you, Dr. Tan, for that question. Maybe I should provide some context. So we've had a couple of waves in Singapore. I think in the initial wave was actually fairly small because there was a very good response at the national level. We are now in the tail end, hopefully, of a second wave that was more substantial. It's actually more than 100-fold of what we had encountered in the initial wave, and that was in a migrant worker community that predominantly stays in dormitories. So Singapore being a very small country, we're just an island city-state, we're very densely packed. So all these has a lot of had a lot of implications on our healthcare system, and I would say that there was a lot of apprehension at the start. Every case we knew was like a tip of the iceberg, and it was like a slow tsunami making its way towards us. And there was a lot of concern about our ICU, our services, and all that. So how did we cope? I think thinking about all the things that elapsed, and I'm sure this experience is mirrored in multiple other sites. There's multiple moving pieces. It's almost chaotic. I think the best phrase I can think of is some kind of an orchestrated plasticity, having the whole organization and all the people adapt to multiple moving pieces, changing requirements, new information, and having the leadership shape all the different divisions and departments in the hospital to respond and to convince them that they need to respond and to change. And I think that has been very helpful for us because we've managed to get that done at a hospital level. But if I could just add a caveat that it's not something that we could accomplish on our own within one hospital. It was a coordinated effort across the whole country that actually enabled us to survive and get through the second surge. That's
Thank you very much. Yeah, thank you very much, Dr. Cheng. Now, Dr. Helbrun. In recent years, as a specialty, we have been striving to become more visible to patients and to more closely integrate in the clinical workspace and directly consult with our clinical colleagues on their patients. How do we build upon these efforts in the era of COVID and social distancing? And also, how do you deal with your colleagues that visit the department and do not wear face masks or practice proper social distancing?
Thank you very much for that question. I think these are all very important issues. I think one of the things, again, that's been really interesting is we've spent a lot of time at Emory taking a leadership role in what the embedded workroom is and how we actually have our reading rooms in the clinical spaces. And, that requires actually moving clinic rooms, taking out the places where patients come in to put radiologists into those spaces. And what we've learned through leveraging our digital communications is that it's actually a lot easier for radiologists to enter the space where our colleagues are working through digital mechanisms. So the work that we have created through our multidisciplinary conferences, leveraging that, it's now much easier to actually send a direct message through some of our secure messaging systems to a colleague and say, hey, let me show you this immediately. And our screen sync, we broke down that barrier to communicating electronically and using screen sharing. So some of the space issues that we used to have on really expanding our in-person and embedded reading room modality, we've accomplished with keeping the same space or even separating out. So I think that's really actually been a really positive thing, is we had a hard time imagining what it looked like doing this embedded clinic remotely, but now we know. And then the second piece of the that you asked about is what do we do when people enter into our spaces and they're not wearing masks? Well, again, we have to take a systemic approach. So Emory Healthcare and most of our healthcare systems are really trying to be leaders in saying that we do this masking because it protects ourselves and protects each other, and it's good for our patients. Our patients want to see us masked. So we can really just say, oh, you're coming into our room, please, have a stack of masks if we need to, or even be able to encourage people. But we've really worked through that way of saying, that it's a positive. I wear my mask to protect you, you wear your mask to protect me. And we just create that culture and enforce that culture of safety throughout the system, and it becomes less and less of a problem.
Yeah, great answer, Dr. Helbron. Now, Dr. Sahani, what would you list as the key elements you're implementing in your healthcare system to future-proof your department against challenges like pandemics that can disrupt your normal operations, as has COVID done?
Thank you, Dr. Tan, that's a great question. And as you can imagine, COVID pandemic is complex and there are many factors you can't control. And there are things to consider what influences patient to come to the hospital, and you are dependent a lot on bringing patient into the system. So first thing I would say is we need to be prepared. We need to always be prepared, leverage technology effectively, using like options we discussed by two speakers, whether it's for remote reading options, deploying the better communication options, looking at efficiencies in the workflow, making sure that we have reserves built in our system. When I look at our own practice, 70% of support to our department is through clinical services. So clinical service has to be robust. So operations are critical there. But you also need to protect your workforce. So there is no simple answer to this. One is be thoughtful of your resources, be prepared with using technology, empower your staff to deploy solutions, monitor your success on a regular basis, have dashboards, KPIs, business intelligence, and data to influence your investments over time, and build reserves for rainy day. That's critical.
Terrific. Thank you, Dushyant. I think we've got time for a number of questions, and the audience has posed a number of them on the webinar. So let me begin. Let me pose this question actually to Dr. Sahani. And this question comes from William Olmsted. Dushyant, do you have plans in your department to bring patients back into the department for example, standard 2-view chest radiographs? Now, with the surge of patients that most of our institutions have seen, or patients under investigation, our efforts have been to obtain, for example, chest radiographs portably to avoid having them come into the department and create issues there. Are there any plans for bringing those, for example, emergency room patients back into the department for standard studies as we would typically do in a non-COVID time?
Jeff, thank you for that question. And Dr. Olmsted, so good to hear from you. So just to take a step back, when we had a surge in the initial hump for COVID pandemic, I think it was a crisis mode we were managing. So we had to take every measure possible, not only to protect other patients, but to protect our workforce. Now, since we have overcome and the initial hump and there is flattening of the curve, we have already started bringing patient back and having a regular schedule. Of course, we are putting all the measure in place of social distancing, PPE, hygiene, and limiting crowding in our waiting areas. But also for tests like radiographs and all that, we have a policy of patient who might be sick, and how do we treat those patients potentially and isolate them, whereas a patient who might not be sick. We continuously monitor patient when they come in for if they have a fever or any symptoms, and accordingly we triage them. Also, because we have a complex health system, we have X-rays, ultrasound, and imaging solutions available at multiple sites. So we leverage those type of solutions that exist. We are looking at screening exams, diagnostic exam versus like ER exams. Now, ED you can control a lot because that's a real time, and you need to provide services where patient coming in. And if your volume is very high, which we have at level 1 trauma centers and all, of course, you cannot have a very restricted portable type of approach. You can't deliver care that way. So.
Terrific, thank you. A number of our viewers have asked questions related to MRI and how you deal with COVID patients. Let me pose this to Dr. Cheng. The questions are, a number of them, they primarily center around how to deal with either patients under investigation or known COVID positive patients who are undergoing MRI. I presume many of these are brain MRIs, given we know that a number of patients with COVID have neurological manifestations. How do you clean machines, deal with the flow of patients with COVID in the MRI area of your hospital?
Thank you for the question, Dr. Klein. So the MR cleaning protocol was something that we scratched our heads long over, because it was something that there was no clear answer to. So first originally we had an MR that was a negative pressure MR, but it was coincidentally undergoing renovation at the time of the surge. So we had a position that we're not going to do MR for the highly infectious cases, convert to CT, use clinical judgment, etc. Then our machine got repaired and we said, now we've got to deal with the problem, right? So we thought about it and we drew lessons from CT, right? So for our first MR of a COVID case, we took everything out from the room that didn't need to be there. We consulted our infection control personnel, specialists for advice. We had to cover lots of things with plastic and make sure that whatever could be removed was removed and protected. Even the table was covered with a sheet, and anything that was a high-touch surface was covered with an additional layer. And of course, we rehearsed the whole thing, get the patient down, in and out as quickly as possible. And usually the difficult ones were the intubated ones on machines, because there's a lot of disconnection of the ventilator, which is an aerosol generating procedure. So we needed to make sure that there was no disconnection of the ventilator from the time the patient is transported down to the MR and out. So a MR compatible ventilator throughout the entire process. Now, after the patient leaves is when the problem starts, right? Because we could wipe down every surface that was high touch. We could UVC the room. But how do we clean the bore? How do we clean those parts deep inside? In SARS, we had a radiographer or a rad tech actually climb into the machine and clean while being inside the bore of the MR. So we searched around and saw that there was some commercial cleaning devices that allow you to extend deep inside a bore. And even coming down, looking at the solutions that we could use to clean was a consultative process with the vendor and our infection control specialist. So we actually sort of clean the bore with a device it's like doing a pull through to clean the bore at 360 degrees. So it's a very laborious process with appropriate solutions. I think that covers the main gist of how we clean and prepare for MR.
Terrific, thank you very much. Next question I want to pose to Dr. Halbrun. Marta, question from Lori Margolis. And she says that reading from home obviously works quite well for physicians, but our technologists have to be physically, obviously, in the workspace. And the question really relates to sharing, perhaps at Emory, how you have supported your staff, your technologists who are really on the front lines, and prevent the development of resentment, given that many of us can work for the most part remotely, whereas they're really in the mix of things.
Yeah, I think this is one of the things where, in some ways, what was our best, our option actually turned out to be the right thing. Also, we got home workstations for approximately half of our faculty. We have a number of things that require faculty to be on site. Barium continued. Procedures continued, all of those activities. But the other thing that actually having faculty on site really gave us that chance to be present, to support our technologists, to hear their concerns, to see what they were experiencing, and then to be the champions for them. And so it really is actually critical that physicians maintain a presence. One of the things that I did when learning from my technologists about how worried they were on having to do so many DVT studies. I mean, they were spending all of their days in the COVID units doing DVT studies and were really worried about their concerns, is it actually gave me the opportunity to walk up to the ICU with them and see their work and see what it was like taking portable chest x-rays, seeing how well our protocols that we had written for wiping down machines, donning and doffing PPE worked. And without having that necessity of being on site, I really couldn't understand what they were saying about their concerns. So it has to be a shared where you have some people who are working offsite, but you continue to have a physician present so that we really do create that team and enforce that team, because we need our technologists to feel safe. We need them to feel supported, and we need to be their advocates if we're going to actually be able to make a diagnosis at the end of the day.
Thank you so much. This is a question from Chitra Saxena. Maybe I'll pose this to Dr. Cheng. She asks, what should be the process? Perhaps you could share the process that you are currently employing for performing aerosolizing studies in your department, particularly lung ventilation scans. How are you dealing with these? Do you have access to same-day rapid test results when you're going to be exposing other patients and staff to potentially patients who are going to undergo these what we consider high risk or highly transmissible studies in our department?
I think for our hospital, we have a list of aerosol generating procedures. So it's not just the scans that you talk about, but if you're doing a barium meal or a CT colonography or something like that, where there's potential for fluids to splash or to be aerosols to be generated. So I think for our hospital, we do not routinely test all patients who come into the department. We have a risk stratified approach. So we work very closely with our infectious disease specialist colleagues, and remember that stratified process, the different wards. I talk about high risk, intermediate risk, and low risk. So those will be screened through both epidemiology. We have a very rich database of clusters where patients, COVID cases come from, and they put all that together. And if the patient fits a certain bill or presents with a prolonged viral pneumonia, they will screen them. So we don't screen everyone routinely, but our PPE is based on procedure, not on the test result of the patient. So even if someone is swab negative, PCR negative, it could be a false negative. So our PPE needs to be pegged to the procedure, and we need to protect ourselves as if the patient might be infected. They could be incubating and having a false negative swab. So we don't go by test results, we go by the risk of the procedure, and we don our PPE accordingly.
Great, thank you. Let me pose the next question to Dr. Sahani. This is a difficult one. I think it's pretty clear that many departments in the United States are facing fairly significant financial difficulties because of the marked drop in volume that we have seen across the country, frankly, related to the surge in COVID patients and the reduction in imaging volumes. How are you, as a chair, dealing with the fact that we were seeing a resurgence in the need for a lot of the studies we delayed or put off doing, versus the fact that you've got real staffing needs to try to accommodate for this relative resurgence in caseload that you're seeing?
Jeff, that's an excellent question, and I think we all need to be thoughtful about that. This pandemic is not just hurting the healthcare, it's hurting almost every services, every professions, economies. And I think in healthcare, we are fortunate and privileged that we get to take care of our patients. And I think that was the main purpose and mission why we pursued medicine. I think what is critical that we need to be cognizant of the emotional toll this pandemic might take on your workforce and employee. So first thing, I'm not concerned about physicians or other health providers working hard. I think any type, it motivates them. Any challenges, it motivates them. That I'm less concerned about. I think the financial recovery will also happen. It is critical to keep them inspired, keep them supported, And for that, what you need to do is you have a frequent informal type of a session where you can listen to them, create small groups, work groups where they connect with each other. Don't create stringent requirements in the department, give some autonomy, flexibility in the schedule, and, create a non-punitive type of approach. And be genuine in your efforts, do the best you can, and create the transparency is what your staff and faculty need. So I know it's complex.
I clearly appreciate that. I want to wrap up by thanking my co-moderator, Dr. Bien Sutan, and of course today's faculty for sharing their expertise with us. Thank you to the viewers for attending today's webinar. Please look into the resources panel for details on how to earn CME credit for this webinar. I would also encourage you to continue the conversation on RSNA's new community site, where your radiology colleagues and RSNA leadership will comment on COVID-related issues and answer questions that you might pose. Please see the chat and resources panel in this webinar for the link to the site. Thank you very much, and please stay safe.